Today on Primary Care, chronic pain. It is estimated that more than 116 million Americans suffer from chronic pain, and African Americans and other minorities are less likely to receive effective treatment.
So I wish that they would figure out how to treat this because it's really frustrating.
Hello and welcome to Primary Care. Although chronic pain is a widespread problem, pain and its treatment are strongly influenced by race and ethnicity, according to the American Medical Association Journal of Ethics. Whites receive more and better pain treatment than African Americans and Hispanics. So how can African Americans gain access to appropriate chronic pain treatment and improve their outcomes? Here with me today to answer that question is our guest, Dr. John Traylor. Dr. Traylor is an anesthesiologist who specializes in the evaluation and management of acute and chronic pain conditions. He is also one of the founders of the Michigan Pain Management Consultants, where he provides pain management and anesthesia care to patients. Dr. Traylor, welcome to Primary Care. So glad to have you, John.
Thank you so much.
Great.
Thank you.
Dr. Traylor, this whole thing of pain is wrecking the nation, all of the issues around pain treatment and what patients get for pain treatment, but you know that's a subject that I'm not thinking haven't heard the end of the story, of course. But in your estimation, how do you define chronic pain, which seems to be our big problem in society? How do you define chronic pain this day and time?
We have defined chronic pain as pain lasting more than 3 months. The bigger picture probably is that pain is normally a good thing. I know that sounds weird, but pain has a protective role.
It's a signal.
It's a signal. It's a signal of danger, tissue damage. That's what lets us know we need to change our path. You touch a hot stove or a thorn on a piece of shrubbery or something of that nature, and you know to avoid it.
The reflexes take place and you have pain.
Absolutely. And so that's what we refer to as acute pain. Short-lived, you usually know exactly why this has occurred. Chronic pain is this maladaptive syndrome, disease, illness that should not occur. So after generally a 3-month period of time, if you're continuing to have pain, you have this diagnosis of chronic pain and something special needs to be done to rid that from your body.
So when we see patients with pain, acute or chronic, a lot of times we're asking them to identify it on a scale 1 to 10. Should we be doing that alone, or should we rely on other measures of the pain to try to quantitate it?
So first and foremost, it needs to be brought to your physician's attention. To try and assess that pain with a numerical value just will not work. It's helpful. It's probably more helpful in terms of the progression of the pain for that particular patient. If you've been having pain, it's a 4 out of 10 and now it's a 6 out of 10, that probably means a lot more than just saying I have a 6 out of 10 pain, because your 6 and my 6 could obviously be quite different.
So we need to drill down a little deeper on the pain itself and ask some surrounding questions to bring it out a little bit more, and not only just to the attention of the doctor, but help them understand the pain a little bit better.
Absolutely. We need to actually sit with the patient and have a conversation. When did your pain begin? What things make your pain worse? I really want to hear the story of your pain. Is your pain constant? Is it intermittent? Is it only when your brother comes to town and stays with you for the weekend? But there are lots of factors that we need to explore so that we can actually truly evaluate your pain.
But currently, obviously, we have ineffective management of chronic pain. We've created part of this problem, but not all of it, and certainly not the answer to correcting chronic pain with some of the approaches that are being taken now. As a result, it leads to adverse outcomes for patients. What are we doing wrong in this approach?
Well, I don't think we are so much doing things wrong, but this is a disease and a treatment in evolution. We spend over $630 billion a year trying to treat pain now, and some would say we're treating it ineffectively. So we need more research, more data. We don't have the perfect drugs. We have other outside influences that may be detrimental, socioeconomic factors. So it's going to take a long time, but I certainly think we're taking steps in the right direction.
The term or the phrase interdisciplinary approach has come into play now. We hear it more often. Explain to the viewing audience what is really meant by an interdisciplinary approach to pain management.
So when we superficially think of pain, we think, let's take a pain pill and make this go away. We know that doesn't work. So in order to treat pain, we're going to have to address a lot of issues. Why you're having the pain. Are there things in your life that are increasing that pain? Should certain things be eliminated from your life? We need multiple specialties, occupational therapists, physical therapists, psychiatrists, psychologists. So it's going to take a large number of players, especially for chronic pain, to get some resolution.
So with this approach, the multiple factor approach to this, do you see that a difference in terms of African Americans and their ability to seek and to get that kind of care as opposed to other populations like non-African Americans, Hispanics, whites? I mean, are we really seeing the differences that make a difference?
So certainly. So there are, again, a lot of factors. Some are socioeconomic. And so if we're on the lower economic scale, then we have fewer resources. If you have fewer resources, then you're going to have certain limitations to accessing care. More disturbingly, however, a lot of the healthcare providers have certain biases, cultural biases, and this has been borne out in numerous studies of late. African Americans in emergency rooms have gotten fewer opioids than non-Hispanic whites.
You get 50 questions and less treatment.
Exactly. And so it's even happened in the pediatric population. So the first thing to do is to bring some awareness that this is occurring. And then we can take the next step towards preventing this from occurring.
So there are some challenges, but there are also some approaches that should make a difference in the outcomes of patients.
Oh, absolutely. Certainly in terms of inequities of analgesics, pain medications, that can readily be taken care of. Just having the knowledge that this is occurring.
What is happening in terms of the other entities that have an effect in terms of our ability to treat pain? What other factors are limiting or enhancing our ability to treat pain? What I'm after here is, do you see the pharmaceutical industry playing a role in this, or do they make a difference up to a point, and then contrary to popular opinion and what we are dealing with in the media, are they making a difference in terms of our ability to treat pain? Do they hinder us? Are they helping us? Do they play a role in this at all?
They certainly do. The pharmaceutical industry supplies us with tools that we can utilize in our toolbox. And so it's not always a solution, but it's certainly a tool that we can utilize. They also have a responsibility to make sure those tools are not easily misused. Opioids, for example, a hot topic now. We're prescribing opioids getting in the wrong hands, opioids that can be easily altered for illicit use is certainly problematic and accounting for many, many deaths. Deaths from opioid abuse now exceed those from alcoholism, suicide, gunshot victims, motor vehicle accidents. So certainly the pharmaceutical industry has some responsibility, along with the rest of us, to try and prevent this escalation.
It's grown from being a drug crisis to being a medical issue more so than a social issue if we listen to all of the talk about this, but suffice it to say, patients still have to be treated for the same, no matter what you call it or how you label it.
They do. We just have to find better ways of treating. And the physicians kind of find themselves in a little bit of a quagmire, so to speak. We have a right to not have pain, which has legal implications even. You should do everything in your power to make sure the patient doesn't have pain. The risk there is you could potentially overtreat, and overtreating with opioids is leading to this opioid epidemic, because many of these fatalities are from prescription opioids.
Hold it right there. We're going to take a break. Next on Primary Care, you will hear how this once active woman is living with the chronic pain disorder, fibromyalgia.
I'm Joe Adams. I'm a pharmacist. I'm also a parent that knows the pain of losing their child to an opiate overdose. We lose 64,000 lives a year due to this epidemic. No one is immune from this. The members of the National Association of Boards of Pharmacy focus on ensuring that pharmacies and pharmacists are providing safe medications and patient services for you and your family. Learn how to keep you and your loved ones safe at nabp.pharmacy.
Living with chronic pain hasn't been easy for Lynn Latham. She was diagnosed with fibromyalgia over 20 years ago, and while she would be the first to admit her frustration with the constant pain, she has learned that the best way to stay active and involved is to pace yourself.
My diagnosis with fibromyalgia I felt was really a blessing because I suffered for years just having back pain and neck pain, and I attribute it to having been rear-ended in a car wreck. The reason I say that was a blessing, although I didn't want to have fibromyalgia, it was a blessing for me because I went through the Arthritis Foundation and found they had a course for like a group class for people with fibromyalgia. And I was just stunned to find I'm in a room full of 20, 30 people with fibromyalgia who, as they told their stories, had suffered for years and years and been told by doctors, it's all in your head and there's nothing really wrong with you. And they'd been through so many tests and been through so many different types of treatments and things, all to no avail because nobody ever diagnosed them with fibromyalgia. It had taken decades before they'd gotten a diagnosis. The doctors don't have a lot that they offer. They offer you medication. They suggest counseling, but I find it's tough because the one doctor who treats the arthritis and also prescribes the pain medication doesn't believe in fibromyalgia, which is frustrating because, like, how can I have a doctor who doesn't even believe I have the condition that I've had for 20 years? But I go to him because that's where I have to go to get my pain medication. So it's frustrating because I feel like he's not treating me, the whole person. He's only wanting to look at my spine and what's happening with my spine, but he doesn't want to look at holistically. So I wish that they would figure out how to treat this because it's really frustrating. And recently I've become even more concerned about that because of the fact that they want to treat it with medication, but the medications that they want to treat with now, because of the whole opioid crisis, they want to scale back or, make a change. But after so many years of taking that medication, now it's like, what am I supposed to do? I don't know what to do. So I wish they'd come up with some options that work. The other thing I think that I would say about having chronic pain is that it can be very discouraging, and that at this point in my life, having had it for over 20 years, I grapple with, there are times when I feel depressed. It's like, am I ever gonna be done with this? God, please. I think at 15 years, I was like, okay, I'm gonna pray this thing off of me or do whatever I have to do. And to still be dealing with it after so many years, it's hard.
Dr. Traylor, what is fibromyalgia? Mrs. Latham's doctor didn't believe that it was a real condition.
So fibromyalgia is a collection of findings. What makes it so difficult is that they can be quite varied from person to person and include so many parts of the body. Many times in medicine, we can key in on a heart condition, a lung condition, a musculoskeletal condition.
One system.
One system. Fibromyalgia involves many systems, and not all of the systems for all of the people. Unfortunately, this leads to a wastebasket term, so to speak, meaning that if we can't explain everything we see, if we can't isolate it to one or two systems, we've got this term that we can put people into and we can get out of this situation. Because when a patient comes to a doctor, they want to leave with a diagnosis.
Exactly.
And so here's this term, fibromyalgia. So it's a very real condition, hard to define. There's no diagnostic test for it. We believe there's an abnormality of the brain and spinal cord in terms of processing pain. But there is no painometer to look at it. There is no MRI to identify it. There's no lab test. So it makes it very difficult, but it's a very real condition.
Do you find it hard to explain it to patients, especially those who might have some element of depression associated with it?
It is difficult to explain. One thing that is really helpful is there are a lot of community groups and a lot of support. So if you can give patients some guidance and they can find these support groups, there are many other people there that have these similar complaints, and they find some comfort in that.
Do cultural beliefs play a role in this? You know, people come to the office, come to the arena of seeking care, and they bring a lot of the mores with them in terms of how they feel about pain and what the causes might be, even what the treatment might be sometime. And they will sometimes give you a little pushback when you recommend things. What kind of cultural difficulties do you run into in advising people with chronic pain?
So there are so many, it's remarkable. Not only do the patients have these cultural differences, the providers have these cultural differences as well. I even ran into a case once where a patient felt the reason she was having pain was because she was being punished by God. And she had to make some type of religious correction in order for her pain to go away. So absolutely, there are many cultural beliefs. There's a whole group of people that feel they should be quite stoic, and we can't even obtain the information from them.
It's hard to draw it out of them.
Absolutely.
Right. And the other end is that some people feel that the only answer is to pray it away, which we believe in prayer. At the same time, we also believe in the abilities that God has given medical community to help people with these conditions.
Sure. I pray the patient will actually tell me what's going on.
Exactly. That's right. Yeah, we need the help. So here again, the chronic pain syndrome now is something that has taken over the media to a certain degree, just depending on which time of day you listen to the news. Or it's in every paper every day in some form or another in this country. What is organized medicine doing to help the country address this problem?
So there are more chronic pain facilities in existence now than there have ever been. And there are more what we call interventional techniques available to us to help us determine why someone has pain and come up with an effective treatment. There are what are called diagnostic injections. So many times when it's difficult to find out why you have a pain, we're able to perform a procedure where we isolate certain parts of the body. For example, your sacroiliac joint. You could freeze this joint and eliminate this as part of your pain and see how much pain relief occurs. Epidural injection. So that there are many avenues that we have now that were not available previously that will help us actually find out why you have the pain and thus be more effective at ridding the body of that pain.
And we have to ask this question, can patients afford this? I mean, the socioeconomic impact on healthcare is real. And when we start talking about specialized treatment for pain, can patients afford it? Do we see people who don't have the ability to afford this suffer more pain or pain from lack of treatment because they can't afford it?
Absolutely, absolutely. As we become more and more sophisticated, our solutions become more and more expensive. And our insurance providers less and less likely to provide financing for these. So that is absolutely a barrier. There are a number of government assistance type programs, and social workers in most hospitals have some program for financial assistance. One of the biggest barriers is that the patient has to be able to come in and fill out the necessary paperwork to even qualify.
Sometimes involves everything from transportation to even being able to answer the questions appropriately.
Certainly, or many times the patient doesn't understand the questions and they're embarrassed to let someone know. So consequently, they look for other avenues for treatment, which in some cases could end up being treatments from the street or illicit drugs, things of that nature.
We're going to go to a break. We'll be right back with more of our discussion on chronic pain with Dr. John Traylor. Stay right there. We'll be right back.
All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become 1 in a million.
Welcome back. We're here with anesthesiologist and pain management specialist, Dr. John Traylor. John, let's talk about medications a little bit. Is this a reasonable approach in modern practice of medicine for most patients in their pain control or pain management to continue to think that we can prescribe oral medications to actually reach the pain or reach the complaint of pain?
It is reasonable. It's not going to be a singular approach, obviously, but we will always need some type of analgesic medication to help with pain, especially acute pain. Often with chronic pain, because many times chronic pain comes from degenerative processes, the aging process. So we're going to need some help with that. The important piece is to add things like exercise, healthy diets, control of other medical processes going on in the body, control of arthritis, ruling out things like lupus, hormonal changes, all those things will be required.
What can people do, especially African Americans, seeing that we suffer disproportionately with most diseases? What can African Americans or patients in general do to improve their access to a pain specialist like yourself?
They need to make their primary care doc aware that they're having these painful processes. That's what actually generates the referral, gets them into a pain center where they can obtain the support groups, the treatments, the further diagnoses. But they have to make a step of letting their primary care doc know that they have pain and not just accepting the pain.
So if someone were to do a study, and someone's always doing a study, if they were to do a study and look at a clinic that serves lower socioeconomic population of patients as opposed to one that does not, in a different zip code, what would be the differences that you could expect in the outcome, since we live in this outcomes-based medicine world? What differences could you expect in terms of evaluating that data?
Well, certainly African American patients, as well as other minorities, access less of the healthcare system for management of chronic pain. A large part of that, I believe, is a lack of comfort in terms of questioning their primary care provider and, I hate to say, but demanding that something be done for that pain.
So recently here in Michigan, we have new rules, new laws in terms of how opioids and pain medications, along with others, are prescribed. As close to 30 states, I'm told now, in the country are doing the same thing. Have these kind of laws help or hurt us in terms of managing pain for our patients?
Both. So the good part is a lot of attention has been brought to the subject of opioid overdose. One thing of concern is, for example, these recent laws that have come into effect, which interestingly are over 650 pages of which are empowering pharmacists, for example. And the pharmacist may deny the patient to fill their prescription for an opioid. That could be potentially problematic because many of these patients really do require their opioid, and they would potentially go into withdrawal, things of that nature. It's hard enough for us as physicians and primary care providers to be unbiased Now you've got to have your pharmacist really believe you
Yes.
in terms of whether to actually distribute the medication that's been prescribed for you by your physician.
So basically, there's a good side and a bad side, and the story hasn't ended yet in terms of this prescription issues.
That's true. Once again, as we kind of alluded to a little earlier, the whole process of this treatment is evolving, and I think will continue to get better. But we certainly have a significant challenge ahead of us.
We've been talking with Dr. John Traylor, anesthesiologist and pain specialist, on the subject of chronic pain. John, you've been most informative, and hopefully we'll get a chance to do this again. Thank you so much for joining us on Primary Care.
Absolutely. Thank you so much for inviting me.
Medical research and literature continues to reveal significant differences between African Americans and other populations in the treatment of chronic pain, making it crucial that we proactively and consistently educate ourselves and then advocate for the best healthcare treatments available. Researching your condition and working to strengthen the communication and relationship with your primary care doctor is a good place to work towards improved outcomes. I'm Dr. Lonnie Joe. We'll see you next time on Primary Care.